Sleep habits are quite common and sometimes could be a contributing factor for eliciting pathology, especially those we are unaware of, and that occurs during a period of time that encompasses 1/3 of our lives. After so many years in practice, I've always been intrigued by asymmetric astigmatism. I felt that maybe I was overlooking something. Why allergy and eye rubbing have been associated with keratoconus, their precise relationship and contribution to disease progression remain to be elucidated. Clinical observation alone makes it difficult to determine their contribution. This film intends to raise awareness of external mechanical factors, especially occurring during sleep time, that appear to play a role in the progression of ectatic corneal disorders such as keratoconus and post-refractive ectasia. The following case reports will highlight the matter at hand. Case number 1 is a 34-year-old white male who presented for routine ophthalmological examination and had the refraction on the screen. Past medical history was significant for atopy. Slit lamp examination revealed signs of chronic papillary allergic conjunctivitis. Plastidisc-based corneal topography displayed here shows slight asymmetry with an incipient cone pattern on the left. Pentacam examination displays a complete different pattern of astigmatism between the eyes. As you can notice, with the rule on the right and against on the left, the belly ambrosial enhanced ectasia is consistent with form thrust keratoconus, although the pachymetry map displays a thicker cornea on the left as seen here. We also performed an ORA examination, displayed here, which shows smaller values for the left, both for the CH and CRF. After further interviewing the patient, he categorically denied being an eye rubber, but he confirmed he usually sleeps on his left side, often adopting a pillow-hugging position that could exert pressure on around the left eye. Case 2 is a 26-year-old white female diagnosed with keratoconus stage 2 on the right and form thrust on the left back in January 2011, as seen on plastidisc-based corneal topography shown here. Refraction at that time is shown here. Past medical history was also significant for atopy. Slit lamp examination also showed signs of chronic papillary conjunctivitis. Rigid gas-permeable contact lenses were prescribed and used irregularly over the time span. She presented for follow-up visit in 2013, with the refraction showed here. Pentacam examination displayed keratoconus grade 2 on the right and grade 1 on the left. ORA plots typical of keratoconus show significant decreased values for CH and CRF for both eyes, lower on the right. She also categorically denied eye rubbing, but confirmed several recollections of awakening with her left hand positioned against her left eye. It has been published in the literature that corneal hysteresis and CRF are poor parameters for discriminating between mild keratoconus and normal corneas. It would be naive to assume that the form thrust keratoconus on the left in case 1 and the progression of keratoconus in case 2 were solely caused by external factors. What other factors play a role in the disease progression in these cases? The debate is open. The first clinical reports on the relation of eye rubbing and external eye pressure with keratoconus asymmetry and progression and post-laser ectasia as well were described by Dr. Alan Carlson from Duke University. He stressed the difficulty of evaluating the contribution of these external mechanical factors on keratoconus progression. He also reported, along with other authors, the association between obstructive sleep apnea, flop eyelid syndrome, and keratoconus. Although much more considerable research efforts have been directed toward corneal collagen cross-linking and its corneal resistance enhancement, on the other hand, further study is recommended to verify the relationship between localized trauma from eye rubbing, mechanical external pressure, and disease progression. The increased awareness among clinicians and keratoconus patients to these potentially detrimental habits may be an important first step toward implementing strategies to slow down the progression of the condition in some patients. Based on our clinical observations and patient feedback, we have been experimenting the use of night masks, which can be found in any drugstore in developing countries, with the insertion of surgical polycarbonate shields as shown here. This modified night mask is rigid enough to prevent external eye pressure from the hand and pillow and could potentially prevent unconscious nocturnal eye rubbing. Other post-LASIK eye shields found in the US market were tried and found to be uncomfortable for overnight wear. Keratoconus has been well described in the literature, yet its etiology remains elusive. Although keratoconus is quite common, both genetic or environmental factors have been implicated. Is there a genetic predisposition that requires a trigger or environmental event to elicit progressive disease, such as eye rubbing and external eye pressure? Do inflammatory mediators play a significant role? Future studies will need to better address and elucidate these contributions to causing keratoconus. Until then, we are recommending the use of the modified night mask with polycarbonate shields inserts for those patients in whom detrimental external eye pressure and sleep position have been established. Thank you very much for your kind attention.